I'm Ellen Tullo, and I've got a lovely mixture of roles now. So firstly, I'm a geriatrician. So I work in some clinics with older people with complex comorbidity, and sometimes Parkinson's. I'm a teacher at the trust that I work for. So I look after the care of the elderly rotations that medical students from Sunderland University come and do. And I'm now also the academic training lead for Sunderland Medical School. So that is encouraging and supporting students who are interested in academic careers to get involved as an undergraduate, and then to help them with that academic pathway once they graduate, so into academic clinical fellowships and beyond. Yeah, okay, so it's not linear. I was a medical student at Newcastle University, and then I was part of the first cohort of foundation doctors. So prior to that, people were house officers and senior house officers, but I was part of the foundation cohort, and struggled a bit clinically in the first year, just in terms of the volume of work and so on. And so actually after F1, I took a year out, and I did a master's in the history of medicine, which was just fabulous, and learned a lot about academic skills, about studying, and the kind of joy of learning for the sake of learning, because I didn't think it was particularly going to add to my clinical career, but from an academic point of view, it was a really nice introduction to that world. So I went back to do core medical training, and again, clinically found things quite difficult, but became at that point interested in teaching, and started doing some teaching sessions for Newcastle medical students. I went on to do a postgraduate certificate in medical education, and again, really enjoyed learning about the academic background to teaching, what worked, what didn't work, what had gone before. And again, enjoyed that academic period of study. So I then became aware of the possibility of an academic clinical fellowship, and was under the wrong impression that this had to be a kind of laboratory type program, doing very clever things in with biomedical science, but was informed that that's not necessarily the case, and these academic clinical fellowships could be used for other fields of practice, including medical education. And so my interest in geriatric medicine and medical education came together, and during the fellowship I looked into the state of play in relation to teaching about geriatric medicine, particularly for undergraduates, and particularly in relation to teaching about dementia. And during that time, came to the decision that I would love to be able to do a PhD and study things further. So I was very fortunate in being given a fellowship by Newcastle Biomedical Research Centre, whose focus was on ageing and long-term conditions, right through sort of translational spectrum from the laboratory stuff, but also into service development and medical education. So that's where my funding came from. And the PhD was great. And whilst I was doing that, I was also delivering teaching at Newcastle University and doing some clinical sessions in geriatric medicine to keep my skills alive. And following that, I wasn't entirely sure what I was going to do next. So I had a period of time actually as a lecturer at Newcastle University, inputting into various different courses, actually mainly postgraduate teaching. And that's where I became involved in supporting other people who wanted to do academic research. So I was teaching on a postgraduate certificate in clinical research, and also outreaching into other programs like the Masters for Healthcare Scientists, and teaching about academic skills. Following that, I decided that I really wanted to get back to the coal face of undergraduate medical education, because in my mind, that's the most important area, particularly in relation to working for older patients. It's really important that medical students, right from the very start, are exposed to the medicine for the population that they're going to serve. And that includes a big proportion of patients with frailty, multiple long-term conditions. And that's really where I wanted to put my focus. So following that, the position at Sunderland Medical School came open for academic training lead, and I jumped at the chance of that, mainly because Sunderland is a new medical school, lots of exciting things happening, and the opportunity to really start to grow academic medicine from scratch. We don't have the same infrastructure as they do at other more established institutions, and I just thought it was a fantastic opportunity to get involved in. So that's what I'm doing now. So I have my fixed clinical sessions, which are on particular days, but outside of that, every day is different, and that's exactly how I like it. Sometimes I have to remind myself what I'm going to be doing and who I'm going to be talking to, but the variation in the roles that I've got means that I talk to lots of different people in different institutions, both nationally and internationally. And so I never quite know what is going to be happening day to day, but it's always interesting. So I do some online meetings, I do face-to-face teaching, and I put together curricula, I put together funding bids, and this all fits around quite nicely around family life and the other things that I like to do. Well, I love the variation, but every day I have the opportunity to interact both with patients and with medical students, and both of those things are very satisfying. In relation to teaching, medical students often are very bright, very driven, and if I can interest them either in medical education or academic medicine or geriatrics, any one of those is a win. And it's great when people talk about the possibility of training as a geriatrician or as an academic. That makes me feel very happy. I think a challenge for everyone working in clinical practice and in the academic world is the frustration around bureaucracy. Things move very, very slowly, and it takes months, sometimes years, to work up a research project, and more time for it actually to have an impact. And that's where I've been drawn back to teaching, in the sense that it's much easier to make a quick change and to see the outcome of that change straight away. Having said that, medical curricula are very slow to change, and there's the challenge of making a curriculum fit for purpose in relation to the population of patients. So, for example, when it comes to ageing and multiple long-term conditions, our curriculum hasn't caught up with the population changes. So we're still teaching a very system-based course, which reflected the patient population of decades ago. And we still haven't yet managed to match our teaching for the patient population that we serve. And that's one of the things that I am trying to do through the various roles that I have. Well, first of all, I'd say go for it. So it's a very rewarding role to be involved both in the actual delivery of teaching, but then also in the planning and the educational science behind that teaching. The nice thing about medical education is that you can start by dipping a toe in the water by doing some teaching, whatever clinical role that you have, and the majority of doctors will do that already, but it can then be ramped up, so you could look for an official role with a medical school or within whichever trust you work in. And then for the majority of people who are interested in the educational science behind teaching, there's the option to do a postgraduate certificate or master's in medical education, and that will tell you whether you want to be involved in that academic side of things. From there, really, there are so many different roles that you can fulfill, and medical education covers a whole host of fields, including things like supervision, quality assurance, and career planning, supporting medical students to decide what they want to do. And most of the time, hospital trusts will be very keen for you to move into those roles. And as our medical student population expands, it's likely that there will be more and more educational roles for people who are interested. So my PhD project was considering how to improve undergraduate medical education about dementia. And whilst I was doing my PhD, the findings of the Francis report were made public. And one of the key learning points from that report was that we were not good at looking after older people with complex comorbidity, including dementia. And on that basis, Health Education England decided to mandate some training around dementia for healthcare professionals. And although my PhD project concentrated on undergraduate medicine, some of the key messages from that PhD project were taken on board by Health Education England in relation to dementia training. So it was good that that important field was recognised. But in terms of day-to-day, I think the greatest impact is role modelling for medical students, both in terms of inspiring them in relation to research and demonstrating the importance of geriatric medicine and as a specialty. So again, if I can encourage people into those roles and get them enthused about it, then that's where day-to-day I have an impact. So in terms of being a good teacher, I think there are some similarities with trying to be a good doctor, which most clinicians will focus on what a patient needs and be patient-centred when they're looking after someone in clinical practice. And there are similarities with teaching in that really what is most important is the learner's needs. And so an ability to work out quickly and responsively what your students want and need is key. And so that definitely requires a level of flexibility, because you may think that you're going to deliver a particular session on a particular topic, but there are times when you do have to change what you're doing in order to make that teaching session effective for that particular group of people. So one of the benefits of the roles that I have is a certain amount of flexibility. And although life is very busy, being involved in teaching and academic medicine means that I have got the scope to move things around in a way that you can't always do with clinical sessions. And it's also allowed me to work less than full time, partly for childcare and partly because I've decided to devote some of my time towards climate activism, in the sense that I think it's a fundamental challenge in relation to population health. So in terms of making a difference, I want to do that locally for patients and for students, but I also think as doctors we have a duty to consider the health of the population at large. And climate change is going to have a big impact on our entire population. So my advice to those setting out would be and this is something that's quite difficult for doctors, is to accept that there will be failure along the way. So many people that go to medical school and work as doctors are not used to being told no or not achieving whatever application that they go for, but that is just an accepted part of academic practice. And I've heard many well-renowned professors talk about their various failures in the past, and so know that you will be joining a group who all have experienced failure but have continued on in their pathways eventually